This is a patient who presented with a slight cough and mild dyspnea, out of proportion to the extensive involvement of the central portion of the lungs. At first glance, we may think in acute pulmonary edema, but note that there are no curly lines, and note that the pulmonary vasculature is not radiographically prominent. Also, there were no cardiac findings suggestive of cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. This is a CT of a patient who had the same disorder on plain radiograph, and the CT shows the central distribution of the densities. And note the lack of vascular engorgement, and note that there is no evidence of pleural effusion and that the heart is not enlarged. This is an example of a pulmonary alveolar proteinosis. The densities of the lung have been described as having a geographic shape. They can also be diffuse, and not always they are perihilar in distribution. Another patient with alveolar proteinosis in the supine position, one can see that the disease is diffusely involving the ventral portion of the lung, which will be the opposite of pulmonary edema, which tends to accumulate in the dependent part of the lung. Note the integrity of the pulmonary vasculature, and note that the vessels are not engorged. Pulmonary alveolar proteinosis is a syndrome where we see abnormal accumulation of an eosinophilic material which represents surfactant that fills the alveoli. We note increased production of alveolar pneumonocytes type 2 cells, or decrease degradation of the surfactant by the macrophages. So either we see excessive surfactant formed by pneumonocyte type 2, or normal formation but decreased resorption. We also know that in alveolar proteinosis, the etiology of this process is not known. It is more commonly seen in males and females, and it was first described when I was a fellow at the Institute of Pathology of the Armed Forces in Washington, D.C. In 1958 by Drs. Rosen, Lebo, and Benjamin Castleman. The clinical features of alveolar proteinosis consist of progressive restrictive lung disease. These patients generally have a non-productive cough. They have a minimal or moderate dyspnea, which is progressive on exertion. They have fatigue. They may have hemoptysis, although this is rare. Also rare is chest pains and fever. It is a process that is most commonly observed in individuals between 20 and 50 years of age. Pulmonary alveolar proteinosis is considered to be a disorder of surfactant homeostasis. It is due to decreased removal of alveolar surfactant rather than increase in its production. Breakdown and removal of surfactant is done by the pneumonocytes type 2. Remember the type 1 is the one involved with gas exchange, and we see granules in these pneumonocytes type 2. We also know that the absorption is primarily by macrophages, and the latter appear to be less involved. In pulmonary alveolar proteinosis, there appears to be interference with the cycle, particularly in the removal of the surfactant by diverse stimuli, such as inorganic particulates, fibrogenic dust, wood products. Some consider that viral infections and antimetabolic drugs are involved in the mechanism of alveolar proteinosis. It can lead to a decrease in the uptake of surfactant. Physical insults associated with pulmonary alveolar proteinosis are inhaled silica, aluminum dust, drugs such as corphentermine and amiodarone, lung toxicity. When we stain these lungs with PAS, that is periodic acid shift, this material appears of a pink color, and the pink color is limited to the interior of the alveolar structures. It is the only process that I know that is a pure alveolar process. There is no evidence of a thickening of the interstitium. There is no accumulation of abnormal cells in the interstitial portions of the lung. The pulmonary alveolar proteinosis material is similar to normal surfactant, except for more serum proteins and immunoglobulins. Expectorated sputum examination by electron microscopy may show laminated concentric structures that are the counterparts to the cytoplasmic inclusions that characterize the alveolar pneumonocyte type 2 cell. Because of these laminated bodies are somewhat at first glance similar to the cyst of pneumocystis carinii. At first glance, the patients are considered that may have PCP pneumonias, and this was the initial confusion in the interpretation of the laminated bodies from sputum analysis. These are histological sections of a patient with pulmonary alveolar proteinosis. On H&E stain, the material is pinkish. It also is of a red color on the PAS stain. Note the integrity of the interstitium. Also note in the top right that alveolar proteinosis affects one area of the lung, and other areas may be absolutely normal. In other words, this is not a totally diffuse process. We also note that in some of the histological sections we see rounded dark bodies that represent the laminated structures that originally were misinterpreted as being due to PCP. Finally, the bottom right shows on the left evidence of PCP pneumonia. On the right, the presence of alveoli filled with this material, the proteinaceous material, but no evidence of cysts. So on special stains, one can recognize the cyst of pneumocystis carinii, as noted on the left side of the slide, but when applying a PAS stain, this material that represent the cyst are not visualized. So it is possible on histological grounds and by the distribution of the pathology to rule out a relatively similar entity that is a PCP. Radiographic findings reveal often symmetric perihilar alveolar infiltrates with a bat wing appearance similar to what one sees with acute pulmonary edema. Asymmetric or unilateral involvement is less frequently seen in about 20% of patients. CT more clearly reveals the distribution of the alveolar involvement, often with striking air bronchograms, and the absence of vascular changes, the absence of interstitial pathology. In this patient, we can see pre and post bronchoalveolar lavage. Following bronchoalveolar lavage, initially we may see focal pulmonary edema, but note that the infiltrates have cleared partially, and this is what is expected from the treatment of pulmonary alveolar proteinosis patients. This is a patient with PCP. The difference with alveolar proteinosis is that in pneumocystis carinii pneumonia, we observe bilaterality of involvement, perihilar in distribution, but cystic changes are very prevalent. If there were only infiltrates, the distinction with alveolar proteinosis would be radiographically impossible. Again, we do not see any vascular engorgement, and these patients are free of cardiac disease.